Hi everyone, my name is Lovasi and welcome back to my radiology review series. In this video, we're going to go over various key imaging concepts with great learning points. So stick around until the end for a quick review and don't forget to drop your questions in the comment section and leave a like. Station 2, describe the images A and B. What are the most likely diagnoses? So for A, notice this particular lesion right here. And then for B, notice this lesion right here. So image A shows a plain film radiograph of the left femur demonstrating a lytic lesion. So this is image A. And then it shows a plain film radiograph or an X-ray of the left femur demonstrating a lytic lesion. This is a lytic lesion in the cortex of the medial diaphysis, metaphysis, and epiphysis of the distal femur, as well as a lamellated periosteal reaction with a Codman's triangle adjacent to the lesion. So this is the Codman's triangle we were talking about. So periosteal reactions are just reactions of the periosteum to the tumor that is growing rapidly. And then image B shows a plain film radiograph of the right knee demonstrating a spiculated or sunburst periosteal reaction with a wide zone of transition on the medial aspect of the proximal tibia. So this is the spiculated or sunburst periosteal reaction, and then it's on the medial aspect of the proximal tibia. So number 2, what is the most likely diagnosis? So both of these features are characteristic for osteosarcoma. So image A is osteosarcoma of the left distal femur, and image B is osteosarcoma of the right proximal tibia. So metastasis to the bone is the most common cause of bone cancer in adults, and it can present as either blastic or lytic lesions. So whenever an adult has bone cancer, it's most likely due to metastasis from another primary cancer. And then prostate cancer is the most common cause of metastasis to the bone in men, breast cancer in women, and lung cancer overall. But multiple myeloma can also cause this too. Then osteosarcoma is the most common primary bone tumor, and it typically affects the metaphyseal regions of long bones, most commonly the distal femur and the proximal tibia. Station 3, describe the image. What is your diagnosis? So the image shows a plain film radiograph in lateral view demonstrating a complete transverse supracondylar fracture with complete posterior displacement of the distal fracture segment. So this is an X-ray in lateral view demonstrating a complete transverse fracture. This is a transverse fracture, as you can see. And then it is a supracondylar fracture. It is above the medial and lateral condyles of the humerus. So what is your diagnosis? Before I mention the diagnosis, I would just like to go over the Gatland classification of supracondylar fractures. So type 1 is undisplaced, type 2 is displaced with an intact posterior cortex, type 3 is displaced in 2 or 3 planes, and then type 4 is not part of the original Gatland classification, as it can only be diagnosed intraoperatively. So this is the Gatland class 3 supracondylar humeral fracture on the left. Station 4, describe the image. What is your diagnosis? So before I read the answer, just notice the fracture here and this particular lytic lesion right here. So number 1, the image shows an epi X-ray of the right femur depicting a subtrochanteric transverse fracture that is displaced. The greater trochanter is right here and the lesser trochanter is right here. And the fracture happens below that, and it's a transverse fracture. So a subtrochanteric fracture would be expected to be below the greater and lesser trochanters of the femur. And then the proximal fracture segment is laterally angulated. So this proximal fracture segment is angulated laterally. Then, surrounding the fracture is a large radiolucent lesion suggestive of an osteolytic lesion. This is the osteolytic lesion that is surrounding the fracture. So number 2, what is your diagnosis? This is a pathological subtrochanteric femoral fracture on the right. This is the right side. And then we're saying this is a pathological fracture because of this lytic lesion that we see here. And then it's a transverse fracture, which is below the greater and lesser trochanters of the femur. Hence our diagnosis, pathological subtrochanteric femoral fracture on the right. Station 5, describe the image. What is your diagnosis? So the image shows an X-ray of the left forearm depicting a fracture of the mid-ulnar diaphysis, as well as a misalignment of the radial head relative to the capitulum of the humerus and the radial notch of the ulna. So there is a fracture of the mid-ulnar diaphysis, and then in addition to that, there is a misalignment of the radial head relative to the capitulum of the humerus and the radial notch of the ulna. Then number 2, what is your diagnosis? So this is an oblique comminuted Monteggia fracture. As you can see, it's oblique, and then this fracture has separated this bone into at least 3 pieces, as you can see here. So this is a comminuted fracture. And then why are we saying this is a Monteggia fracture? Remember, a Monteggia fracture is a fracture in the proximal third of the ulna with a proximal dislocation of the radial head. So there is a fracture of the proximal ulna along with an associated dislocation of the radial head, as you can see here. Station 6, describe the image and state the most likely diagnosis. Describe the features of breast calcifications that indicate malignancy. Describe the technique used to obtain this image and the standard mammographic views. Mention one other reliable diagnostic tool you would alternatively use and why. So the image shows a mediolateral oblique mammogram depicting nodular and dense fibroglandular tissue. And then the foci of calcifications are scattered around the breast in keeping with fibrocystic breast disease. So as you can see here, the foci of calcifications are scattered around the breast, which is in keeping with fibrocystic breast disease, also known as fibrocystic change. And then the features of breast calcifications that indicate malignancy. So these would be clustered, high-density calcifications of different shapes and sizes with irregular edges. So that simply means whenever you have clustered and high-density, hyperattenuating calcifications of different shapes and sizes with irregular edges, those particular features indicate malignancy. But that is not the case in this example, because as you can see, the foci of calcifications are scattered around the breast in keeping with fibrocystic changes, which is a benign condition of the breast. Then number 3, describe the technique used to obtain this image and the standard mammographic views. So the technique is such that the patient is first instructed not to use any deodorants on the chest or underarms to avoid artifacts, and then she is positioned either standing or seated depending on mobility, and her breast is slightly compressed between the 2 plates of the mammography machine to spread out the tissue and reduce motion blur. Then the standard views of a mammogram include craniocaudal view and mediolateral oblique view. So this particular example showed us a mediolateral oblique view of a mammogram. Then number 4, mention one other reliable diagnostic tool you would alternatively use and why. So ultrasound is something that we would alternatively use, and we would use this specifically in a case where the patient is below 35 years old, because young women have denser breast tissue and also breast masses are usually dense. So if you try to visualize something that is dense over something that is dense, it would be very hard to see, which is why ultrasound is usually used in young women who have dense breasts to assess for dense masses. Station 7, describe the image. What is the most likely diagnosis? Outline the management of this pathology. So Station 7 showed us an epi X-ray of the shoulder in which the humeral head is projected medially and inferiorly. What we were describing is that the humeral head was projected medially and inferiorly. And then the humeral head and the outline of the glenoid are incongruent. The glenoid cavity is right here and the humeral head is right here. So this is an anterior shoulder dislocation. So this projection of the humeral head medially and inferiorly is pathognomonic for an anterior shoulder dislocation. And then the management of this pathology: analgesia and sedation, reduction. So how you reduce this particular dislocation is via external rotation plus adduction. And then after that, you administer post-reduction care, which is an arm sling. So when you make the arm sling, the hand should be resting in an external rotation position. And lastly, rehabilitation or physiotherapy and follow-up after 2 to 3 weeks of immobilization with the arm sling. Station 8, describe the image. What is the most likely diagnosis? Outline the management of this pathology. So notice that unlike in the previous example, where the humeral head was projected medially and inferiorly, in this particular case, the humerus stays at the same level. So the image shows an epi X-ray of the shoulder in which the humeral head is internally rotated, giving it the classic light bulb appearance. So normally in a frontal view of the humerus, you should be able to notice this prominence of the greater tubercle right here. But then when the humerus is internally rotated like this, you're going to notice that you're not going to be able to see the greater tubercle of the humerus, giving the humerus this rounded, smooth contour, which is described by the radiologists as a light bulb appearance. So there is internal rotation of the humeral head in this particular case, which is why the humeral head appears very smooth and rounded. And then no inferior displacement of the humeral head is seen. So basically here we're just trying to justify that this is not an anterior shoulder dislocation, because in an anterior shoulder dislocation, the humerus is displaced inferiorly and medially. And then the light bulb appearance is pathognomonic for a posterior shoulder dislocation. And then the management of this pathology is quite similar as that in an anterior shoulder dislocation. And the only difference is that in the reduction process, we do external rotation plus abduction. Station 9, describe the image. What is the most likely diagnosis? So the image shows flowing paravertebral ossification of the facet joints, giving the appearance of a bamboo spine. As you can see, there is ossification right here, giving the appearance of a bamboo spine. So as you can see, this particular spine looks like a bamboo. So the diagnosis is ankylosing spondylitis. Station 10, we've got this particular history. So describe the image. What is the most likely diagnosis? So the image shows a lateral X-ray of the neck demonstrating an enlarged epiglottis as evidenced by the thumbprint sign. So this is the thumbprint sign right here, which is demonstrating an enlarged epiglottis. So the diagnosis is acute epiglottitis. That's pretty much it for today. Make sure to leave a like if you found this video helpful. Until next time.